Welcome, ladies and gentlemen, to the Lake Superior QIN Behavioral Health Initiative Kickoff Call. Your host for today is Gavin Bates. Mr. Bates, you may begin.
Thank you. And once again, I would like to thank everyone for attending today's Lake Superior Quality Innovation Network Behavioral Health Initiative Kickoff. We're very excited, and I'm going to turn it over to our project coordinator, Gerlach.
Thanks, Gavin. Hi, everyone. My name is Caitlin. I am a project coordinator at MPRO, which is Michigan's Quality Improvement Organization. And speaking with me today will be Janelle Shearer. She's the program manager at Stratis in Minnesota. And then Jody, Rothe, who is at MetaStar. She is the Medicare manager at that QIO in Wisconsin. So why we asked you to log in today is we have a new exciting behavioral health initiative that we're kicking off today. And we wanted to give you a little bit more information about it and how you can get involved. So if we look at our objectives today, I will be providing an overview of the Lake Superior Quality Innovation Network and the work that we do under our CMS contract. I will also be giving you an introduction of the behavioral health project that I mentioned under this Medicare umbrella. We will go over state-specific activities surrounding behavioral health that may impact and align with this project. I will talk about benefits and expectations of participating in this work, and then how you can get involved. So for those of you on the call that aren't familiar with LSQIN, which is the Lake Superior Quality Innovation Network, and the work that we do, I'll give you a brief overview of that. The LSQIN falls under the Quality Improvement Organization Funds under CMS. We work in scopes of work which are contracts under CMS, and we are currently in our 11th scope of work. Some changes were made to the QIO program for this 11th scope of work, which started in August 1st of 2014 and goes to July 31st of 2019. What CMS has asked us to do, which is a little bit different, is combine with a regional team, which is called the Quality Innovation Network. So it is made up of multiple QIOs to have more of a regional impact on the quality improvement work that we do. Another change is that we now work in 5-year scope instead of 3-year scope. So hopefully this will allow us to make a little bit more of an impact and be able to see some of the outcomes of our quality improvement efforts. We also were asked to choose to apply for either the beneficiary protection piece of the QIO contract or the quality improvement piece of the contract, which our 3 states combined have chosen to work on the quality improvement portion of the contract. So LSQIN is made up of Stratis, which is Minnesota, MetaStar, which is the QIO in Wisconsin, and MPRO, which is the QIO in Michigan. So our regional and state-specific strategies will be implemented to employ the CMS contract and improve overall care for Medicare fee-for-service beneficiaries in our state. So I'll give you a little bit of a task overview of what falls under this CMS contract. We work clockwise. I'll start at the top with our cardiac project. We're looking at reducing disparities in the cardiac population. It's mainly embedded in primary care, and we are exploring the measures that are associated with quality reporting and the incentive programs to help make a difference in this category. If you look at the second project, it is focused on diabetes and reducing disparities in that patient population. It is also embedded in primary care, and there is a big push for partnering throughout the state to provide DSME classes to Medicare beneficiaries with this project. The third project is our Meaningful Use project. We're looking at meeting meaningful use requirements in both primary care and the hospital setting, and the appropriate and effective HIP adoption and use. The fourth project is our Adult Immunizations project. This is a little bit unique because it is only in Michigan. Minnesota and Wisconsin are not participating in this project, but it looks to improve influenza, pneumococcal, and shingles vaccination rates in Michigan. The fifth one is care coordination. The goals of this project are to work with cross-setting providers to reduce the 30-day all-cause readmission rate to hospitals and reduce adverse drug events related to hypoglycemics, opioids, and anticoagulants, as medication issues are a big driving factor in readmission. So the next one is our behavioral health project, which I will go into detail in the next few slides. Following that is our quality incentives and reporting project. We're looking at things like TQRS measures in primary care, the quality reporting measures in acute care setting, and meeting some of those requirements so that you can get your value-based modifier or value-based purchasing incentives. If you look at the next one, it is our nursing home project. That project is focused on improving quality measures, especially the use of inappropriate antipsychotic medications, and then also improving mobility in nursing home residents. The last one is hospital safety. The focus on this project is to improve the rates of C. difficile, CLADI, which is catheter-associated urinary tract infections, CLAD-C, which is your central line-associated bloodstream infections, and then also looking at ventilator-associated events. So our behavioral health project is formally known as Improving Identification of Depression and Alcohol Use Disorder in Primary Care and Care Transitions for Behavioral Health Conditions. So we know that behavioral health conditions are very under-identified in the Medicare population, and there's a great opportunity in primary care settings, especially to improve screening and implement integrated care approaches to improve disease management and patient outcomes. As well, transitions of care, especially for the complex comorbid patient population, are challenging. Coordinating care for these patient populations can result in decreased hospitalizations and better management of chronic conditions in the community setting rather than in the hospital or in an inpatient setting. So this project really looks at two parts of the work that we're already doing under our CMS contract. It pairs our ambulatory quality improvement efforts with our care coordination project. And we are evaluated on the primary care setting and the inpatient psychiatric facility setting. And I will get into that now. So the first piece is the primary care setting. So what are we trying to do here? Our goal is to recruit 200 physicians for each state. So it will be, 200 physician practices for each state. So that will total 600 physician practices for our region across the 3 states. We're looking to increase screening rates for depression and alcohol use, and that will be evaluated through Medicare fee-for-service claims. We are also looking to improve coordination of care for patients with behavioral health conditions. So identifying these patients, managing them in the primary care setting, and also appropriate referral to resources that are needed to manage their behavioral health conditions so that they can more appropriately manage their chronic disease. So then in the inpatient psychiatric facility, this includes both standalone facilities as well as inpatient psychiatric units embedded in hospitals. So we're looking to recruit 5 inpatient psychiatric facilities, which I'll abbreviate as an IPF for this call, for each state, which will total 15 for the region. And our measures for this, we are looking to improve the 7 and 30-day follow-up for post-acute behavioral health resources. So your patients that are discharged from your inpatient psych facility, we're looking to get them in early with their behavioral health providers, whether it's a social worker, a psychologist, a psychiatrist, psychiatric nurse practitioner. Those all qualify for a behavioral health follow-up visit. We're also looking to reduce the 30-day all-cause hospital readmission rate. So your patients that leave the inpatient psychiatric facility and return to the hospital for any reason within 30 days. The reason we're looking at this is because, for example, your congestive heart failure patients that were admitted for a psychiatric stay for their depression. If their depression is not well managed in the outpatient setting, they may come back with exacerbated symptoms of their CHF. Same for, say, your schizophrenic patients that need to manage their diabetes very well. It's really pairing the behavioral health and the chronic disease management to this measure. So now we'll go a little bit into the state-specific implications for each of these. So in Michigan specifically, MPRO participated in a 12-month special innovation project through CMS in our last contract. It ended last summer, but we had a great platform where we were tasked with improving the readmission rate for patients with a chronic disease diagnosis as well as a behavioral health diagnosis. And this was really a great platform for us for where we're going with this project. We're looking to engage more of the primary care physicians in our efforts, one, because we're evaluated on it, and then two, because this is a great place to help manage and identify some of these behavioral health conditions. Another great aspect of participating in that special innovation project is that we really got a great understanding of the drive for the community mental health authorities throughout the state. There's a lot going on with integration initiatives in Michigan, and the community mental health authorities are really working with their partners, downstream and acute care partners, to improve the care both on the medical side and the behavioral health side. So we're looking to continue that relationship with all of our partners statewide in this project. So what I'll do now is I'll hand it over to Minnesota, Janelle Shearer at Stratis Health, to tell us a little bit about some state-specific details in Minnesota.
Thanks, Caitlin. Hi, everybody. In Minnesota, we have quite a number of initiatives related to behavioral health. And so our focus is on aligning our efforts with all the work that is happening already in our state so that we can avoid duplication, move in the same direction, and progress toward a common goal. So I just want to talk about several things here in relation to this initiative. The Behavioral Health Advisory Council is a group that Stratis Health started facilitating just recently. It includes organizations such as the Institute for Clinical Systems Improvement, our Department of Health and Human Services, NAMI, or the National Alliance on Mental Health Illness, our Minnesota Academy of Family Physicians, Minnesota Community Measurement, and several health systems. And we're looking to align with other behavioral health initiatives and build on what others have already done. In our RARE campaign, which was a statewide campaign to reduce admissions, standing for Reducing Avoidable Readmissions Effectively, there were a number of collaboratives, and one of them was a mental health collaborative, which consisted of 13 inpatient psych facilities that work to improve care transitions for people with mental illness. So we plan to continue the work of this collaborative and integrate the recommended actions that were developed for this group. And then thirdly, I list here the Minnesota Community Measures. We plan to work with Minnesota Community Measurement to gather data and refine measures for improving screening and follow-up for patients with mental illness. So that's it for Minnesota for right now, and I'll turn it over to Jody Rothe from MetaStar in Wisconsin.
Thank you, Janelle. Hello, everyone. In Wisconsin, we're doing similar efforts to make sure that we're aligning stakeholders and looking at where there's similar work and how we can team the work and be better together and therefore reduce conflicting priorities to the physician practices. So we are working with the Wisconsin Primary Health Care Association, and we have an expert that is on our team that has experience with behavioral health integration, the screening, brief intervention, or referral to treatment, as well as motivational interviewing. We've also reached out to our statewide Transition of Care Steering Committee that includes stakeholders such as the Wisconsin Hospital Association, the Office of Rural Health, the Long-Term Care Association, the Wisconsin Medical Society, and others to really also look at our needs in the state as well as the region to look at what we can do to reduce readmissions and make sure that people are getting the right care at the right time at the lowest cost, as well as aligning the work with other physician practice initiatives like the Quality Reporting Program. Thank you. And with that, I'll take that back to Caitlin, and we'll be opening it up for any questions.
Yeah, operator, can you please open the line for Q&A?
Certainly. Ladies and gentlemen, if you'd like to ask a question, please press the number 1 key on your phone. Again, if you'd like to ask a question, please press 1 on your touch-tone phone. We currently do not have any questions in queue at this time.
Okay.
Take your time, and please let us know of any questions.
While we're waiting for questions to get in the queue, Caitlin, if you could advance the slide one more. Tomorrow we have another learning session on depression and chronic disease, prevalence, cause, and interventions. It's at noon Eastern, 11 a.m. Central. The host or the presenter will be Dr. John Briles, who, if you were on our atypical antipsychotics learning session last month, he is the same presenter, and you can register for that still at the link on the screen.
Okay, we do have a question from Greg with Molina Healthcare. Go ahead.
Hey, Caitlin, this is Greg. How are you this afternoon?
I'm good. Nice to hear from you, Greg.
Yeah, what would be the role of Molina in this initiative here in Michigan?
So the role of Molina would probably be in, as well as other payers, would be in the care coordination component. I think that any community-based organizations or any organizations that we're not formally evaluated on are going to be key in the timely follow-up and also helping to improve the culture of readmissions in the inpatient psychiatric realm.
Okay, well, did you be reaching out to myself or Dr. Briles to let us know how we can contribute?
I sure will. I do want to let you know that Dr. Briles has actually been a great physician champion for us, and he will continue to do that for this work. So we plan to tap into your knowledge for a lot of our learning sessions as well.
Good, I appreciate that because I'd very much like to use this as part of our NCQA responsibility.
That sounds great. We'll connect with you, okay, Craig?
Thank you.
Again, ladies and gentlemen, if you'd like to ask a question over the phone, please press 1. We currently do not have any questions at this time.
Caitlin, if anyone out there is curious about joining the initiative, what should they do?
So if anybody is interested, you can contact myself. I can put my email address in the chat box, and then I'll ask Minnesota and Wisconsin to go ahead and put your email addresses in the chat box as well. And you can contact any of your state leads to get involved in the initiative.
We have another question from Greg with Molina Healthcare. Go ahead.
Caitlin, will the slides be available to us?
Yep, so this call has been recorded today, and we will share it with everybody.
Okay.
We can also make the actual slides available in the description of the recording that we'll post on YouTube.
Once again, ladies and gentlemen, if you'd like to ask a question, please press 1 on your touch-tone phone.
There's a question in the chat from Barb saying, what are the benefits and expectations of participants?
So I can go ahead and take that, and anybody from my other 2 partner states can chime in. I think benefits of participation, there's a big push for integrating behavioral health into your care coordination work and your chronic disease management. Obviously, it's very underdiagnosed, and it's a key component in ensuring that, especially your Medicare fee-for-service patients, as well as all patients, are effectively managing their symptoms in the community as best they can. So I think expectations of participants, we will ask you to sign a formal participation agreement. We can also email you, we call it our one-pager, it's an informational handout, and we will offer to also meet with you either via phone or in person to formally recruit you. I think that our state-specific strategies for recruitment vary a little bit, so you'll want to contact your state lead for that. But expectations would be that you participate in our learning sessions. You actively work with us to try and meet our evaluation requirements. So that would be improving your screening rates in the primary care office, and then improving your readmission rates and your follow-up rates in the inpatient psychiatric facility. Other expectations is that you share best practices. So if you have a great idea, you share it with the partners in the work. Did I cover it all, Jody and Janelle?
Thank you, Caitlin. This is Jody. I would just add, too, that you would have access to our team so that we can provide technical assistance and help you reach the goal. And we'll also have data that we can give to the physician practices to continue that technical assistance.
Hi, and this is Janelle. I don't remember if you announced that it is free to the participants.
Yes, this initiative, like all of the other ones that you saw on the slide at the beginning of this webinar, they're all no cost to the participants.
I do want to make a correction for the Michigan contact. It looks like we also have Christy that you can contact. So feel free to either use my email address, Caitlin, or you can contact Christy, who helps coordinate all of our Medicare programs.
Once again, ladies and gentlemen, if you'd like to ask a question over the phone, please press 1. We currently do not have any questions in queue at this time.
All right. Well, I'd like to thank everyone again for attending. Please note the contact emails and phone numbers on this slide, as well as in the chat. If you would like to get more information about any of our upcoming events or for this initiative, just contact those emails, those people in those states, and we will make sure to get back to you as quick as possible. I'd like to thank all of our presenters for doing such a great job today, and all of you for last time. Thank you for attending, and we hope to see you join this initiative.
Ladies and gentlemen, this concludes your conference. You may have.
Good job, gentlemen. Thank you. Good job, Caitlin and Janelle.
Thank you. You guys did a great job as well.